Hello, good evening. My name's Chris Russell, fertility specialist with New Life IVF. Welcome to tonight's webinar, Male and Female Fertility Testing, your guide to what's involved. We did promise Professor Martin Healy would be here tonight, but unfortunately he's at home with COVID, so you're stuck with me, and I'll be joined, of course, by Dr. Hugo Fernandes, who is ready to start the presentation. So I'll invite Hugo up. I'll be with you later. We do like the session to be interactive, and what I mean by that is we love your questions. So please send your questions through in whatever way is convenient. You can either use the chat function within Vimeo, or you can email us. The email address is newlife@newlifeivf.com.au. We look forward to getting to your questions at the end of the session. So here's Hugo. I'll be back later.
Well, good evening, everyone. It's good to be on line again. It's been a little while since I've done a webinar. Today's presentation is on male and female fertility testing, and as Chris said, send through those questions. It's always enjoyable to get your questions at the end of the presentation and see if you can stump us. It's an interesting topic because we as a fertility specialists talk about this topic every day with pretty much every patient. We order tests, and we need to explain why we're doing those tests. I think it's important that you guys understand also why the tests are being ordered. So what is fertility testing? So first thing to say is that there's no one test that is the test for infertility. The reality is that you need multiple tests, and we take a history and we do blood tests or ultrasounds, and then we bring all that together to give an idea of where you are in the and where your sort of body is in the fertility realm. So it's a set of investigations or tests that look at your unique ability to conceive naturally, get pregnant, and have children. So what is it? It's a test that is meant to give you information, and that information is meant to help you make choices and to plan. It's not a list of tests. It's not 30 tests that you go out and do. It's a handful of tests that are selected individually for you based on your circumstances, whether you've had children before, the reason you're coming in, and what you're trying to get out of these tests. So it's a different set of tests for different people. And why would you get tested? Well, I sort of thought that there's two groups of people that get tested. So those are the people who are either trying to currently get pregnant and are having some trouble, and then those that are trying to plan for the future. So the current difficulty group could be people who are have had children before but are now struggling, who have never had children but who are definitely sort of trying at this stage to get pregnant and may not have been successful over many months or years. The planning group is a group that maybe isn't ready right now to have children, but wants the information and wants the ability and the power to sort of make decisions for the future. Some of these are short-term decisions, so this is a group of people who think it's about time that they try to conceive and just want to get things ready, make sure things are right to go for maybe starting the next 3 to 6 months. There's the long-termers, who are people who just want to know that things are on track. So this may be a 25-year-old woman coming out of university, about to start a corporate job, maybe not ready to have children until, say, her early 30s. She just wants to make sure that things are on track. And then there are those that have current concerns. So these are people who want to know how things are right now for reasons such as going under for surgery, being unwell, maybe about to be treated for cancer. So we want to know what their fertility status is now and whether we need to do anything about it or help preserve it. So these are the two main groups. So when do they get tested? Well, the current difficulty group, it's really dependent on age and how long you've been trying for. So if you have a regular menstrual cycle, and if you are having regular unprotected intercourse, and you're under 35, then it's about one year. 12 months you should probably come in and see a doctor if you have not been successful. If you're over 35, then you probably shouldn't do this for more than about 6 months before you get seen by a doctor or a specialist. Obviously, if you're a little bit older, say you're over 40, if your cycles are not regular, if you have other issues such as endometriosis, an infection, if you've had surgery that may have altered your anatomy, if you've previously had issues trying to get pregnant, or if you have a known male factor issue, then you should probably come and get reviewed sooner. The planning group, well, there really is no set time, but I would say now. Chris will go into this a little bit more, but age is really important, and you're never going to be younger than you are right now. You're never going to have more eggs than you're going to have right now, and they're never going to be of better quality. So now would be the answer to the planners, and if not now, then whenever it is that you want answers or you want to discuss possibilities. So what is involved in fertility testing? It's a doctor's assessment, and this can be a history and a physical examination, assessment of ovulation, assessment of your ovarian reserve, and we'll go into that in a sec, assessment of quality, assess the uterus, the tubes, and then also evaluate the sperm. We can't sort of forget the man. So a doctor's assessment is essentially just a history, and a history is actually really important and forms an important part of fertility assessment, because you can glean so much from taking a proper history. How many tests you need, you may only need 1 or 2 more tests to help you achieve a pregnancy or get an idea of where you are. It may prompt other tests, it may prompt a decision to have treatment straight away. So some of the important factors are duration. Duration is how long have you been trying? Is it 1 month, 6 months, 12 months? Have you tried before? Have you been successful before? What's been previous outcomes? Have you had any treatment? Were they successful? Duration is also important because often couples will come to me and say, we've not been using contraception we've been trying to conceive for 6 months or so. And the follow-up question to that is, how long have you not used contraception? And some couples will say, 7 years. So the reality is they've not been able to conceive for 7 years. It's not just the 6 months that they've been trying. Then we have sort of female-centric questions. So these to do with the menstrual history or their cycles. Are they regular? How many days between the cycles? Is there any pain? Is the bleeding heavy? All of these point to pathology, endometriosis, growths, follicles, polyps, etc. that could interfere with fertility. Obstetric history. Have you been pregnant before? How many miscarriages have you had? When did they occur? What was done about them? Did you need curettes? Were they sort of spontaneous? Was there any genetic testing as a result of these? Your gynecological history. Do you have an endometriosis? Do you have a history that sounds like endometriosis? Ovarian cysts. Have you had any treatment before? STDs. Have you been on the pill? All questions that will help steer your fertility assessment. A male assessment usually revolves around development and trauma, and by that I mean their physical development. Did the guy reach the milestones like his peers at school in terms of pubic hair growth, increase in size and stature, facial hair growth? Were there any issues when they were smaller? Did they have infections, the mumps, etc.? Did they have normal testicular development, or were they born with the testes down or sort of retained in the abdomen? And then the trauma one was literally, were there any physical traumas through sport or sort of rough play, or even trauma by way of surgery? Have you had any hernias, etc., operated on? The remainder of the history, which is sexual and medical, surgical and genetic, etc., are common to both the male and the female. Obviously, it's important to know what previous treatments you've had, whether any of these could have affected your fertility. Some of the surgeries, primarily on in the abdomen, or hernia type surgeries, can affect fertility. And in terms of genetics, is there anything that runs through the family that we should be aware of that could make it harder to get pregnant or increase your chances of miscarriage? Maybe your mother or your auntie or your sister has struggled to get pregnant, and that could point one direction or the other. And then obviously there's all the lifestyle things, your weight, your height. Do you smoke? Do you do any other drugs? Do you drink? How much exercise do you do? All of these help us make decisions. So we'll move on to some of the actual tests now. And these tests, as I said, are guided by the history. There's about a handful of them, and you may know some of these tests. You may have already read about them. You may have already had them performed, and you may not understand why they were being performed or what they actually mean. So I like to sort of give some information, some science behind the test beforehand, because it means that you'll understand why the test is being done and what it actually means for you, rather than just being some vague number. So here we have a normal female menstrual cycle, which goes for about 28 days on average. And it looks rather complicated. You can see that there's some stuff happening down below in the down here in the ovaries, and we've got a follicle growing and then ovulating. We've got a whole bunch of squiggly lines here which represent the different interaction of hormones. This top one's temperature, and there's a picture down here to do with the uterus and what's happening in there. So it's all really sort of complicated, and there's a lot going on. So I'm going to simplify it to oops, it's sort of gone off the screen. To simplify it to its bare basics. And the reality is a cycle is 28 days, and it's made up of two halves. The first half is called the follicular phase, and it's called that because, as you can see down below here, we have some follicles, which are little cysts with an egg inside, growing. And so they grow for about 2 weeks before you get ovulation. And because they're called follicles, this is called the follicular phase. Once you ovulate, this little cyst becomes this yellow thing called the corpus luteum, and this is what produces the hormone that keeps the pregnancy going. So for 2 weeks you have this hormone. If you're pregnant, this is what will keep you pregnant. And because this is the corpus luteum, this is called the luteal phase. So it's really easy. 2 weeks, 2 weeks period, 2 weeks, 2 weeks period. And this is what occurs over and over. The luteal phase, this second half, is nearly always 14 days. And so when your cycle is shorter or longer, it's this first half that changes. If you have a shorter cycle, then this here will be shorter. And if you have a longer cycle, then this follicular phase could be 20 days instead of 14. But generally, we're going to say it's 2 weeks. You'll have ovulation, which means an egg will come out, and then you've got another 2 weeks before your next period. So I've just added some hormones onto here, and that's what all these squiggly lines are. So when we're testing for ovulation, when we're testing to see whether you actually do ovulate, it's these hormones that we're testing for. You may be familiar with these two tests, day 21 progesterone and LH testing. Without even doing these tests, and just based purely on the history, I often will tell my patients, I can almost guarantee that you're ovulating regularly because you've got a 28-day cycle. Even a patient who comes to me and has like a 32 or 33-day cycle, if it's continuously 32 to 3 days, month on month, then I can almost guarantee that they're ovulating. They may have a slightly longer cycle, but the fact that it is so regular tells me that their hormones are actually working and they are ovulating. They've just got a slightly different cycle. So these tests I could do to prove that that's the case, or to establish when they're actually occurring. So I won't, it may not be a day 21, for instance. So if we move on back to the chart, what's a day 21 progesterone? Well, it's a blood test done on day 21 to measure the progesterone. And you can see this purple line, it rises really high in the middle of the luteal phase. Once you've ovulated, you get progesterone. Now it's called a day 21 because it's done on day 21, but the reality is it can be done anywhere around that time. And I often tell my patients do it somewhere between day 18 to 23. You can see it stays elevated for quite a while, so it doesn't have to be on day 21. The second test, which is LH testing or luteinizing hormone testing, is this purple line. So in the middle of your cycle, you get a rise in this hormone. It's what causes the follicle to pop and release an egg. And you can do a urine test around here. You can do a blood test around here to detect this rise. This is one of the fancier urine tests. It's an electronic one, but some of them are just a stick with a line on it, similar to a pregnancy test. It's done here because that's when it's meant to be the highest. If either of these tests are positive, then you're ovulating. And if they're negative, then you're possibly still ovulating, just not at the right time. And it's our job to try and work out why. So the second set of tests is to assess ovarian reserve. Now, ovarian reserve is sort of a way of saying how many eggs do you have in storage, how many eggs do you have in your ovaries. It's a way of testing for the quantity of eggs and also your reproductive potential. And there are three main tests that we can order to establish this. So one is the AMH, or anti-Mullerian hormone, also an antral follicle count, and then a day 3 FSH, which is less common. First to say, there's no ideal test, so we often use several. I, for instance, use AMH and antral follicle count as my regular tests. Occasionally, I'll have a day 3 result, just because it's been done, but usually it's the first two. So if we go back to the science of it, female egg count. Now, some patients know this, but many don't, that know that women are born with all the eggs they're ever going to have. Whereas a guy produces sperm at all the time, and this is a sort of a 3-month process, so they've always got a sort of fresh supply. Women don't have the opportunity to do this. They're born with all the eggs they have, and in fact the highest number of eggs they ever have is when they were 20 weeks in utero, and at that point they had 6 to 7 million eggs. By the time you're born, you've already dropped this down to about 1.5 million eggs, and by the time that you're actually able to use it, because you've gone through puberty, you're actually down to 350,000. So that's a significant drop from where you started. That number keeps dropping, as the diagram shows, down to commonly referred to as 0, which is menopause. No more eggs equals menopause. The reality, that's not true. There's still several thousand eggs at the point of menopause. It's too hard for them to come out, and so there's no function anymore. So, but 350,000 eggs from 6 or 7 million is quite a significant drop. Now, the good thing to know about this is that even though there's only 350,000 eggs, you only have about 350 periods. So you have many, many, many more eggs than you need for your cycles. So anti-Mullerian hormone is also known as the egg timer test. There's various other names, but these are the two common names. And essentially it's a hormone that's secreted by these follicles, and it's by the cells that live around the follicles. Now, I can't look at your ovaries and count how many eggs. I can't look at them and say you've got 100,000 eggs there. So we need another marker for it. And this hormone is secreted by the cells that live around follicles. So as your follicle or your egg number falls, then this hormone level will also fall. So it acts sort of as a surrogate marker for number of eggs. The benefit of it is it can actually be done at any time of the month. There's no, it doesn't have to be with a period or day 21. And it's pretty consistent regardless of when you do it throughout the month. It's also pretty consistent month to month, and probably within a year it's reasonably consistent. It does fall over time, so if you do it and then do it 2 years later, it should be lower. But it's not the kind of test that I recommend you do every month or every 6 months even. It's the kind of test that you do once a year to show a change over time in a normal circumstance. The other benefit is it actually correlates really well with the number of eggs that you have. It's used not only for giving us information about your fertility and your prospects for the future. If we go on to do IVF, it's used as a way of dosing you and giving you an understanding of your possible outcome. It's pretty sensitive marker for being over responsive to our hormones or being under responsive to our hormones. What it does not do is predict live birth. So you can have the highest AMH, the most brilliant number, but it does not predict that you're going to be fertile and have a child. It's purely a predictor of how many eggs you have. This is a common chart that you get with the AMH, and sort of divides into 3 groups. The group in the middle, the orange group, is essentially average. The green group means obviously you've got lots of a high number, which means a lot of eggs, but that's also a group that have a polycystic ovarian syndrome. So high AMH is also correlates really well with likelihood of PCOS. The bottom group, the red group, no one ever wants to be in a red group. So the red group means that you've got likely to have a low count of eggs. What it does not mean is that you're infertile. It just means that you don't have as many eggs as the next lady of the same age. And that's one of the important factors of all these tests. None of these tests will tell you how many eggs you have in your ovaries. What they do is compare you to other women your own age. They say you're a 32-year-old woman and your AMH is 28, which means you're in the high normal level for your age group. That's what these tests do. So if we move on to the second test, we'll talk a little bit about follicular development. So you may have seen a chart like this before, a diagram like this, and essentially it's showing the growth of an egg over time. The eggs, when they're stored in the ovaries, are called primordial follicles. And to grow that from that point to the point of actually ovulating and being able to get fertilized is about 150 days. So it takes a little bit longer than it does for a guy. What's important to know is that this process is occurring all the time. At all times, there is a batch of eggs that's starting this development and starting to grow on this 150-day journey. So much so that once you've hit puberty, you're losing about 1,000 follicles per month. So 1,000 of these little primordial follicles are starting this journey to the point of ovulation, or the potential for ovulation. However, of those 1,000, only one will actually ovulate in that month. So it's probably a good thing that you have 350,000 eggs at that point. This leads us on to antral follicle count, which is one of the second tests. So a follicle, which I've been discussing, is a little cyst in the ovary which contains an immature egg. It grows over time, increasing in maturity and hopefully to the point that it can be fertilized. When the antral follicle count is done, it's a transvaginal ultrasound where they look at your ovaries and they look and count how many of these cysts exist. You're looking for the cysts that are about 8 to 10 millimeters in size, but they'll also count the ones that are smaller than that if they can see them on ultrasound. It's important that it's done in the first few days of your cycle. This one is time dependent because that is when things are most stable in the ovaries. After this, you start to get growth of the cysts so that you can ovulate. It reflects the test or the study or the number that you get reflects your current available eggs. And by that I mean how many eggs do you have in your ovaries right now that are usable. It is a good test and correlates with poor responders. So if you have a low number of follicles, you're going to have pretty low chance of success with IVF or with stimulation, and which means you sort of more likely to need treatment. If you've got a really good number or it's an average number, that doesn't give us as much information. You may do well, you may not do well. And again, this test is not a predictor of live birth. You can have an absolute fantastic follicle count. It still does not mean that you're going to have a child. This is what an ultrasound would look like. You can see there's 1 to 10 on there. So this ovary has 10 follicles. They're all roughly the same size, but some are slightly smaller, slightly bigger. And this is a poor antral follicle count because there's only 2. The reason this number is so important is because of what it represents in terms of fertility. So as I explain this to my patients, at the start of any month, you have a basket of eggs that are ready to be used. And in this second image, you can see 10 eggs. So we'd say there's 10 on each side, so that's 20. So this basket has 20 eggs, and as I've said to you, one of those eggs is going to be selected to grow, and that's the one that will ovulate and can potentially fertilize. And that leaves another 19 eggs. So what happens to those 19 eggs? Well, once one of them's been selected and is growing, those other 19 eggs actually die. They just melt away, get dissolved, and the body absorbs them. It's as if they didn't exist. What we do in IVF or in any fertility treatment is we try to make as many of those remaining 19 eggs grow. And we do that by giving you hormones. And we can't make all of the 19 grow, but we try to make as many of them as possible. And often it's about half of that number. So when patients say to me with IVF, you're taking my eggs and you're going to diminish my count, that's actually not true. What we're doing in IVF is actually rescuing eggs. So of those extra 19 eggs, if we're able to collect 10, well then that's an excellent result. You can see why having a low antral follicle count is not a very good result. If it's only 2, then the best we could potentially do is collect 1 or 2 eggs, and the reality is we may actually get 1 or 0. So the higher your follicle count is, the better your chances of fertility, and that's why we do an antral follicle count. Day 3 FSH is a less common test. This works on the premise that early in your cycle, your body produces this hormone called FSH. It's produced in the brain, and it stands for follicle stimulating hormone. It stimulates the follicle to grow, and it starts being secreted early in the cycle. Now, when you have a lot of eggs, the amount of FSH that's required to make them grow is only a small amount. But as you decrease the number of eggs that you have in your ovaries, they become more resistant to this hormone, and they need larger doses and larger amounts to be released by the ovaries. So if you do a day 3 FSH and you have an elevated number, then what it's suggesting is that your brain is working overtime to try and produce hormones to push out eggs. And obviously if it has to do that, then you mustn't have a very good egg supply. Any number under 10 is considered normal, so this is considered an adequate reserve. A medium number between 10 and 15 is borderline. You'll probably still be able to get some eggs from these ovaries, but you sort of need to get a move on. And any number over 15 is considered high, and it's probably unlikely that you'll be able to achieve a pregnancy using your own eggs from these ovaries. Just so you know, a number over about 20 is considered menopausal, and whilst we don't really use this test for diagnosing menopause, if you consistently have a number over 20, then you're probably going to be in the menopausal range, or at least perimenopausal. So, assessing ovarian reserve, what it's actually doing is comparing you to other women of your own age. We interpret the tests in context of the entire clinical picture. It's not only these results, it's how it fits in with your history and your examination. Low reserves of eggs, so low AMH, low follicle counts, suggest that you're going to be a poor responder to treatment, and that you're going to have a poor chance of getting pregnant. That ipsi litera is that you probably should get a move on with treatment and get into sort of more aggressive or more proactive treatments such as IVF. What's important to remember though is that low or poor reserves or poor numbers do not mean that you are infertile. If you have an antral follicle count of 5, but you have a regular cycle, then by definition you are fertile, because you are putting out an egg every month. You may not have many eggs there, but you're still putting them out every month, and you're able to achieve a pregnancy. So they're the main and most common tests. We're going to move on to quality and some other tests that are possible, and I'm going to get Chris back to do this second part of the presentation, which will start.
Thank you, Hugo, very, very much. So I'm going to dive in now and take over where Hugo left off. Hugo obviously talking a lot about eggs, and now I'm going to talk about other things that you need to get pregnant, which are a good functioning uterus, good fallopian tubes, and good quality sperm. And a question we're often asked, as Hugo alluded to, is, Chris, Hugo, can you test the quality of my eggs? And unfortunately, we would love to be able to do that, but there is no good test of that at all. And the only way we can really assess what your egg quality might be like is to look at your age, and it's that simple. And what we do see is that if you have a look at this graph, it sort of shows your natural fertility rates, which is this line here. It's a little bit busy, this graph, but it shows that when your chance of getting pregnant in any given month is fairly consistent until you hit about age 30, and then it declines from slightly from age 30 to 35, and then starts declining a little bit more dramatically. And apart from sort of having a look at where you sit on this graph, there's not much we can do to assess egg quality, unfortunately. However, at the end of the day, really how good quality your eggs are is the proof is in the pudding, as they say. If you get pregnant easily, then you've probably got better quality eggs. If it's harder to get pregnant, or if you do IVF and you're having issues with egg quality, that's where you'll find out. So really, until you try to get pregnant and try to use your eggs, you don't really know what your egg quality is like. Very, very important when you're trying to get pregnant naturally to assess whether you have any issues with your uterus and with your fallopian tube. Now, uterus is really important because that's where the pregnancy grows, and without a good quality lining and a nice normal shaped uterus, that can be a little bit harder. And similarly, to get a natural pregnancy, you need for there to be no blockages in your fallopian tubes. So you could have the most wonderful eggs in the world, you could have the highest egg supply, and you could have fabulous sperm, but if they can't meet in the fallopian tube because there's blockages there, you're never going to get pregnant. So it's really important that any fertility assessment looks at these two factors, and that's what I'm going to talk to you about now. Broadly, the best ways of looking at your uterus and your fallopian tubes is two options really. One is to do an ultrasound, and all ultrasounds will look at your ovaries and all ultrasounds will look at your uterus, but only very specific ultrasounds can test your fallopian tubes. And we sort of broadly call these ultrasounds a test of tubal patency. They're also called HSG or a hysterosalpingogram. They've got lots of different names, but they all attempt to do the same thing. The alternative, of course, is to do a hysteroscopy, which is an operation where we put a camera inside your uterus and have a look at the lining. It's a very, very effective way of checking, as is a laparoscopy, which is a camera through your belly button that looks at your uterus, fallopian tubes and ovaries internally. But obviously it's an operation, so there are some issues that go with that. So we'll go through these two tests and talk about them and compare the pros and cons. To talk about an ultrasound, the best way to do an ultrasound is internally. So by what we mean by that is an ultrasound probe is inserted vaginally, and what that does is it gets the probe nice and close to your uterus, nice and close to your ovaries, where we can get really good quality images. And what we always sort of suggest about doing internal ultrasounds is to make sure you're doing it at a clinic where they're really very good at it. And there are some clinics that will ultrasound your uterus and your pancreas and your heart, and they'll do echoes and they'll look at your kidneys, and they do all of those things as well as they can. But there are some clinics that all they do all day every day is to scan your uterus, your fallopian tubes, your ovaries and your baby once you're pregnant. And as a consequence of that, they get to be very, very good at it. So I must admit, when I talk to my patients, I do prefer that they get as good a quality ultrasound as they possibly can. The sort of things we're looking for on ultrasound is there any issues with the uterus? So a common problem with the uterus might be uterine fibroids, and depending on the finding, fibroids can be very normal, or they can be, they can cause no problems getting pregnant, or in certain circumstances they can cause definite problems getting pregnant. So it's really important to get that good quality scan and to discuss it with a fertility specialist, because like I mentioned, some fibroids are completely harmless, others are particularly bothersome. Other things that can be seen on ultrasound are endometrial polyps. So you can have little growths in the inside of your uterus, little dangly bits of tissue that make it harder for you for a pregnancy to implant, and they can be quite commonly seen on ultrasound. So an ultrasound's a good step to check for those. Endometriosis is a very common condition, and everyone's heard of endometriosis before. They've heard the word endometriosis, but they don't always know what it is. And just in case you're not sure, endometriosis is a condition where the lining of your uterus, so I'll use my little arrow here, hopefully you can see that. So the tissue that lines your uterus, sometimes we find it in spots that it shouldn't be. So sometimes we find that it's growing on the outside of the uterus, around the fallopian tubes, around the ovaries. In this picture you can see a big lump of endometriosis growing on the bladder there, and the ultrasound can be useful in determining whether you might have endometriosis. Now, ultrasound's not perfect at it because sometimes deposits of endometriosis are very small and they just can't be seen on ultrasound. In other circumstances, though, the endometriosis can be quite large nodules, up to 5 millimetres to 10 millimetres in size. Sometimes there are endometriotic cysts within your ovaries, and they can be really seen very well on ultrasound, whereas those smaller deposits just can't be. You may well ask, why are we even interested in endometriosis? Well, there's a few reasons for that. One, it might be outside of fertility. It might be causing you some symptoms. It might be giving you pain, for instance. But from a fertility point of view, we know that women with endometriosis tend to find it a little bit harder to get pregnant. Now, this is certainly not to say that you can't get pregnant with endometriosis, and it's really important to understand that. And I must admit, I get really upset when I meet a woman who says, "Oh, I was diagnosed with endometriosis 5 years ago, and Dr. whoever said I'll never be able to have a baby, or I'll never get pregnant naturally." I've never heard anything more silly in all my life than that, but I do hear it all the time. So it is really important that we diagnose it and we accept that it does have an impact on fertility, but it certainly does not make it impossible. We also know that sometimes treating your endometriosis makes it easier for you to get pregnant. I won't go into all the details of that tonight. That's at least an hour of talking from Hugo to discuss that topic, and we'll save that up. But for the moment, if we just accept that it's important to diagnose endometriosis and deal with it if it's there from a fertility point of view. As Hugo mentioned earlier, the ultrasound's really good at imaging your ovaries, so it'll give you a really good, accurate follicle count and an assessment of ovarian reserve. And finally, so that's a nice little side effect of the ultrasound, is checking your ovaries, but we're mostly talking about structural things here, and the other structural thing that's really important is whether there's blockages in your fallopian tubes. And as you can see on this little picture here, it's a diagram of what happens during an ultrasound when you're having your tubes assessed. And again, this test in particular really is only done in specialised gynecology and fertility centres, so you need to be mindful of that when booking in. And what the clinic will do is first thing they'll do is bring you in at the right time of your cycle. Now, people having this test by definition are usually trying to get pregnant, so what we don't want to do is do anything that might jeopardise your pregnancy. So therefore, we like to do it after your period because we know you're generally not pregnant, but before ovulation has occurred. What we don't want to do is to do it a week after ovulation and your little egg is swimming down your fallopian tube and we pump the fluid through and wash it away. That's not what we want. So it's important that it's done at the right time. So the first thing is get the timing right. The second thing is they will bring you in and do an internal ultrasound, and at the same time there will be a doctor, usually a gynecologist, in that clinic who specialised in ultrasound, and they will put a speculum in your vagina and pass a little tube through your cervix. And what that allows the doctor to do is then push some fluid through your uterus. And if you have a look at this top diagram here, you can see the little tube going through the cervix, and then the doctor is pumping some bubbly water and then taking pictures to see whether that bubbly water can make it all the way through your fallopian tubes and out the other end. And if you can see the bubbly water making it from the inside of your cervix all the way out the other end, we know there's no blockages. If the bubbly water can get through, the eggs will get through and the sperm will get through, no problems. On the other hand though, occasionally if there's blockages in your fallopian tube, as is in the bottom picture, the fluid just won't be able to make it through. Now, it's important to know that with the ultrasound test of tubal patency, if it doesn't show that the fluid goes through your tube, it doesn't absolutely guarantee that there's a blockage, although it does mean that it's quite likely. The reason I say that is occasionally the ultrasound can get it wrong, perhaps about 10% of the time, and suggest that the tubes are blocked when ultimately they are open. You may well therefore ask, how do we know that the fallopian tubes are open? Well, one reason is we sometimes see women with potential blockages and they get pregnant naturally, which proves that there's no blockage there. The other way is that often if I have a patient, for instance, who is young and otherwise fit and healthy and has good sperm, and the ultrasound shows that there might be blockages on the fallopian tubes, we may say, oh, well, maybe we'll do some further testing to find out for sure. And that's probably where a laparoscopy is a touch more reliable than the ultrasound, is that we consider that a laparoscopy to check tubal patency is the gold standard. If that shows that they're blocked, we are almost certain that they are blocked. So To talk about the hysteroscopy and the laparoscopy, these are surgical procedures, so very different to the ultrasound that's done in the ultrasound clinic. For a surgical procedure, the first difference is you need an anaesthetic, so you need to be put off to sleep in an operating theatre by an anaesthetist. Once we've got you asleep, we then insert a very, very fine tube through your cervix, and that's got a little camera embedded in the end, and that allows us to look directly at the lining of your uterus. And ultrasound is, like I mentioned, is very good at picking up things like polyps, but again, the hysteroscopy is even better. I've had quite a number of patients over the years where they've had an ultrasound that suggested that a polyp is there, and we've gone to do a hysteroscopy and found that there is no polyp. Lots of people also have stories of ultrasounds being normal, and we do a hysteroscopy and we find there's a septum there, which is an anomaly within the uterus where there's an additional piece of tissue growing down the middle. So we've all got stories of how ultrasounds have got things a little bit wrong, although on the whole they are very good. But ultimately the hysteroscopy is the gold standard. It really does confirm that there's issues there or completely exclude them. Once you've had the hysteroscopy, you would then move on to do a laparoscopy. Now that's a little bit more involved again, and what it involves is putting an incision through your belly button, so quite a small incision, about 8 millimeters in size, so very small, and again a camera is inserted through that hole. And with that camera, we're able to blow your your abdomen up full of air, and that gives us room to move things around and have a good look at your uterus, fallopian tubes and ovaries. Now, to be able to do that, you do need a second incision to be able to insert a second instrument, and that's what that picture there on the left shows, and that allows us to look at the uterus, tubes and ovaries. And then at that point, we put similar to what happens with the ultrasound, we put a little tube through your cervix, and we pump some fluid through, and we look directly at the fallopian tubes and see how your tubes actually behave upon filling, and that will tell us definitively whether they are open or blocked. The other advantage to laparoscopy is that it does give us a really definitive picture about endometriosis. Now, I mentioned earlier the ultrasounds are okay at detecting endometriosis. The laparoscopy, again, is if there's endometriosis there, it will be seen at laparoscopy. The other thing about laparoscopy is it does give us the opportunity to treat the endometriosis and remove it, which is generally considered to improve your chance of getting pregnant for a few months after having the endometriosis removed. We also think that tubal flushing can be beneficial at improving natural pregnancy rates as well. So it's quite difficult to decide as a patient. Now, it's not always the doctor's decision what to do. It really is the patient's decision as to how to assess her fallopian tubes, and I think it's really important to have a discussion with your doctor to understand and discuss the advantages and the disadvantages of the two approaches. The nice thing about having an ultrasound is you drive to the clinic, and whilst it's very painful it's very painful having the tubal patency test. A normal ultrasound not painful, but it's very painful having the tubal patency test. But once it's over, it's done. You walk back to your car, you drive home, you go about the rest of your day. Whereas a laparoscopy, whilst you won't feel a thing whilst you're asleep, you won't feel the fluid going through your fallopian tubes, you won't get those severe cramps, but you are having an anaesthetic, you are having incisions through your abdomen, and whilst you do find out more information this way, you do need to recover at home for a few days and have a few days off work before you can return to all your usual activities. So it isn't quite as clear cut to say that one is better than the other. Like Hugo mentioned, everything in fertility is about making tailored, customised decisions that are the right decision and the right plan for each individual patient and their partner if they have one. So we've talked a lot about female investigations and testing for women, and I often sympathise with my female patients because they have to have a whole lot of tests to find out how their fertility is going. But for men, they really have one test and one test only, and by God, don't they complain about doing it. But yes, there's only one test for men, and that is to do a sperm test. And very, very easy to do a sperm test. We just get the man to ejaculate into a little cup, and then provide that sample to the testing laboratory. And we have a testing laboratory at New Life IVF. It's very, very good. It is highly specialised at looking at sperm. We sometimes see the more generalised clinics, similar to ultrasound, where some of the generalised clinics we don't always get reliable results. As you know, we see sometimes some unreliable results in other clinics, but you can be really confident with the New Life lab that whatever they tell us is the result, we know that it's really reliable, and that's what we're dealing with. So when you do your sperm test with New Life, there's a couple of ways of going about it. Like I mentioned, ejaculate into a cup. You can either do that at home and bring it into the clinic. As long as you get it there within an hour of the sample being produced, we're absolutely fine. So plenty of time to get it in. We do like you to bring it in with an appointment. So you can't just sort of do it tomorrow and run it in. You've got to pre-plan, arrange a time, because when that sperm arrives, one of the reasons New Life is so reliable is that we've got to have scientists ready to go to look at your sperm to give it the best chance of being assessed properly. The alternative to doing it at home and running it in is we have a couple of sperm collection rooms. So they're sort of purpose-designed rooms that are very private and discreet, where you can produce your sample and then drop it off straight at the laboratory. And different people like to do different things. Some men find it a little bit stressful having to do it in a foreign environment. Others prefer that it's getting there absolutely on time without the stress of worrying about the red lights and the traffic. So that's how we go about doing the sperm test. I'll talk about a little bit more about the results in a minute, but the other thing to say is if we ever do find abnormalities in your sperm test, one of the first things we ever do is to repeat it. And the reason we do that is you do see quite a lot of variability in sperm test results for the exact same man if you do it after a period of time. And again, every fertility specialist has got a story about how they saw Mr. Whatever and he produced a sample that was completely terrible, and 2 months later we did another test and it was completely fine. So we do see some really some wild discrepancies in results from day to day and week to week. So it's always really important to repeat it if you do get an erroneous result, and that way you'll get a true indication of what your sperm is like most of the time. But what are we even looking at? So we're looking at the count. So we're looking at, in that semen sample, how many sperm are there. Obviously, the more the better. A high count does increase the chance of a natural pregnancy, and a lower count reduces it. So really important to check the count. The next thing we like to look at is the motility, and that talks about whether the sperm are moving. And if you see in that little picture that's been flashing away at us in the bottom left of the screen, that's of sperm swimming. And you can see a lot of the sperm, certainly not all of the sperm, but a lot of the sperm is swimming around quite purposefully in there, and it looks like quite a nice sperm sample. You'll see that there are also some sperm sitting there that aren't doing much. That's okay, that's to be expected. We like about 30 to 40% of your sperm at least to be swimming. The next thing we like to look at is the morphology of the sperm, and everyone sort of, if you were listening in biology class in Year 10, you think back to what a sperm is meant to look like. It's meant to look like a nice little tadpole with a nice round head, long swishy tail that propels it along. And we actually, when we do a sperm test, we have a look at the sperm and see what percentage of your sperm meet those characteristics. And as a species, humans have pretty poor quality sperm, it must be said, and we are happy if 5% of your sperm have a normal appearance and look like a normal tadpole. So we accept 95% being abnormal and consider that's okay from a fertility point of view. Some of the things we look for and some of the things we see from a morphology point of view, we sometimes see that the head is too small, the head is too big, the head can be a funny shape, sometimes they have two heads, sometimes they have funky tails. We see all sorts of things, but what we're really looking at is what percentage of your sperm have a nice normal appearance like that sperm on the left. One of the things that isn't always included in a sperm test result, and what I think is a really important measure, is the total motile count. And what the total motile count is looking at is saying, in the entire sample you've given us, how many sperm was there that was swimming in the right direction. And I find personally that's the best measure in terms of making decisions about fertility, whether you have a good chance of conceiving naturally, whether you're a good candidate for intrauterine insemination or IUI, whether you need IVF, and indeed whether you need IVF with ICSI, ICSI being when you inject a sperm into the egg. So the motile count is really useful for that, and the other key one is the morphology. The individual count and motility together aren't as reliable because you can have a really exceedingly high count and a lower motility, and that may ultimately be normal, or you could have a count that is kind of in the normal range and motility that's kind of in the normal range, and you might see a GP or an inexperienced specialist and they say it's all fine, but when you put it together you've got a reduced total motile count, which is clinically significant. So I've run out of things to talk about when it comes to sperm and uterus tubes, and I think Hugo's definitely run out of things to say about eggs and egg numbers. So we're going to go through your questions now, and again, if you'd like to ask us a question, please send it through to newlife@newlifeivf.com.au, and we will get to that question shortly, or use the chat feature within Vimeo. So I'm going to hand over to Hugo now, who's going to take the first few questions.
Time. So this is always a good time where we like getting your questions and being stumped. So keep them coming through on the two features that Chris said, either by emails or in the chat feature. So one of the first questions was about AMH, and this patient said that they'd had an AMH before and the doctor had mentioned that the result can go up and down, whereas I said it was rather consistent. And that is true and untrue. So if all matters being equal, if you do an AMH at one lab, and they'll give you a result. If you repeat it at another lab, say a competitor lab, at around about the same time, the result will be essentially the same, maybe slightly different, but off by 1 or 2. So we don't get down to semantics of the numbers being, like 10 or 11. If you do it over a period of a month, it doesn't change. It's again hovers around the same. If you do it over a year, it can change. It can move up and down. Why? Because as I explained, your AMH does fall over time. But there are other factors actually that change your AMH. It's not that it's your body that's having a negative effect on your body, it's that the hormone can be affected by other factors. So there's not much that makes the number go up. The main one that makes it go up is PCOS. So if you have polycystic ovaries, you're going to have a high AMH. And as I showed in that chart earlier with the sort of the green, red and yellow, the top bit is polycystic ovaries. So that is pretty much the only thing that gets your AMH high. Actually, the other one is if you've got a tumour in the ovary that's producing estrogen. So they're the two things that will make it higher. Generally, we're dealing with lower numbers of it being low, and you come in and say, I've got a terrible number. Is it a genuine number? And there are quite a few things that can make the number go down. The most common, other than it being a true result, the most common one is being on the pill. So if you're been on the oral contraceptive, your number will be lower. If you've been on it, probably within the previous 3 to 4 months, the number will probably still be low. So I wouldn't repeat the AMH. I wouldn't do the AMH within a few months of being on the pill. This applies to other sort of anti-hormone medications. If you've had trauma to the ovaries, that will affect your AMH. So if you've had surgery, if you've had recent surgery, if you've had a cyst removed, if you've had pelvic surgery and they've interacted with the ovary, maybe not directly operated on it, they will all cause your AMH to fall. If you've had chemotherapy, that will make it fall. Smoking has a negative effect on AMH, and it will pull the AMH level down if you're a current smoker. The good news though is if you stop smoking, your AMH levels will improve, which is one of the other reasons to add to the million on why you shouldn't be smoking in pregnancy. Things like endometriosis will also pull down your AMH for 2 reasons. One, it seems to have a negative effect just by itself on AMH, even if it's not on the ovary. If it's on the sidewall, it seems to have this negative effect. But if it's on the ovary and you get a cyst of endometriosis called an endometrioma, that will injure the ovary, often destroys the tissue, and will actually reduce your egg count. And so that's why it's having a negative effect. So they're all things that can have negative effects on your AMH. But all those things being equal, if you're just sort of walking in and getting an AMH result because you want to understand your fertility and none of those apply, then yeah, it's going to be a true result. As an aside, the other thing that I've actually found in general in my practice, which I've always found really interesting, is AMH and antral follicle count. I've found to be a very similar number, so you can check it out. It depends what the units that the test is done in, but if you look at your follicle count and you look at your AMH, you'll often find that the numbers are very similar. Now, this is just a coincidence that this occurs, but if it is and the numbers are similar, then you're probably it's probably a true result. If they're off, if you've got an AMH that's high and your follicle count is low, then one of the tests is going to be wrong. That's just not how things work. So I'll pass over to Chris. I think he's got a good question coming up.
Thank you, Hugo. Next question. What is the chance of successful pregnancy in cases of adenomyosis and in the context of infertility and some miscarriages? Can these be linked? Yeah, it can be. I think adenomyosis is an important diagnosis from a fertility point of view, and mostly issues that adenomyosis can cause is difficulties with implantation. So when you have a fertilised egg and it tries to implant in the lining, it is a little bit less likely in patients who have adenomyosis if you compare them to patients who don't. But again, just like I mentioned earlier, I've seen many patients who've been told that they're not going to get pregnant because of endometriosis. That's not the case. You can still get pregnant with endometriosis just like you can get pregnant with adenomyosis. It's just a little bit harder. So there are always going to be other factors that are probably more important than adenomyosis, and they are probably your age is probably the most important thing. And the younger you are, the more chances that gives you of getting pregnant, and the more chances you have of having a successful pregnancy. So the adenomyosis is a factor, but it's not everything. The other thing I would also say is that it's always important that if you've had a number of miscarriages, it's probably good to have a thorough assessment of why. Because if you've had an ultrasound and it's shown adenomyosis, fine. There might be other things that need to be checked out on blood tests, and there might be other clues as to why you're finding it difficult to get pregnant. So I'd recommend, rather than don't focus just on the adenomyosis, look at things from a global point of view and put it in its context. And certainly you can have a baby with adenomyosis. So that's all we've got time for this evening. Thank you for joining us. It's been our great pleasure to talk to you about these topics. The webinar series will continue, and if you want to see what other webinars we've got planned later in the year, please have a look at newlifeivf.com.au/events. Until then, thanks for your attention and good night.